I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is a virtual care blueprint. We have a very special friend joining us tonight, but before that, let me introduce my co-host and moderator of the chat, Dr. Dan Mccarter. Dr. Dan.
Hey, Faisel. It's great to be with you again this evening.
It is wonderful to be with you. And now, today is definitely feeling like one of those days. It's only Tuesday, and it already feels like it's like Thursday or Friday.
Well, with your recent travel schedule, I can only imagine.
Oh my gosh. We're back out again, that's for sure. Well, tonight's topic is very special, and the friend joining us is really the person who really helped us get out there, first getting on Instagram, and we go to Instagram Live, and then we got this LinkedIn Live, and from the LinkedIn Live doing the simulcast, our very special friend, Robert Longyear. Robert.
Hey, Faisel, good to be back.
Oh my gosh, it is so great to have you here. Isn't this so fancy? This is so different compared to...
Yeah, things have really upgraded since Instagram Live and my really long hair. So
your long hair, me at a campsite walking around.
Oh yeah, you did it from the camper one of those first times too. It's hard to believe it's been almost it's been a year and a couple months since we did the first one together.
Yeah, it's unbelievable actually, Well, Robert, it's great to have you back, and congratulations with your new book.
Oh, thank you. Yes, it's a lot of people show up, they're really jazzed about the book, but it's always fake, right? Because you're just so glad to be done with it. You love what you put into it, and you're just so glad to have gone over it 150 times, and by the time it comes out, you're like, good.
I remember, yeah, actually, before we went live, we were just catching up, and I remember now that it was one of our early conversations, doing the interview for the book, and it was at the time when we made the switch as an organization from, we have a model that's high touch, in person, frequent visits, and we had to make the switch from seeing patients in person regularly on a monthly basis, which was just a routine, to virtual. And we were able to make that switch actually pretty quickly. Within a week, it was 6 days, we were able to make the switch from seeing patients in person to doing it virtually. And I remember in those early days, I was worried about how seniors, our average patient is 72 plus years old, multiple chronic medical conditions. They live in underserved neighborhoods across the country. And I was worried about seniors embracing the televisits, the video visits, and thank God for grandchildren. Literally thank God for grandchildren, because patients like my father's a ChenMed patient. He's turning 70 next month. And yeah, he won't FaceTime my youngest brother in Texas. We live in Florida. But he will definitely FaceTime his children, to be close with his grandchildren. And so when we made the switch from in-person visits to televisits and televideo visits, we got lumped in as the primary care delivery team in with this niche group of people, the grandchildren and the loved ones of our patients. And so there was an intimacy that occurred. Patients suddenly started, to show us around their living situation And I was able to say, hey, I don't think that that's safe to have that there. I'm worried you could trip over that. Or we'd be talking about lifestyle, making some changes with their diet, and they would take me to their cupboard and show me what they've got in the cupboard. They opened the fridge and other. Besides that, unless you go physically in the home, you don't get that kind of you can't get that kind of view. So it was
Right.
wonderful. It was wonderful. Very intimate. It was a different type of intimacy.
Yeah, absolutely. And, obviously I'm a big believer in, virtual care and telemedicine. And, I obviously have read a book on it. And, there's a lot of different benefits of why this is the case. And most commonly, when it comes to telemedicine or virtual care, the number one cited thing is access, right? People can access a doctor anywhere they have a smartphone, a computer, and the internet, right? And that's the first thing that comes up when you hear people say, oh, telemedicine. But access is just sort of scratching the surface of what our new technologies can allow us to do with patients. And the book really takes us on a journey from the early days of telemedicine back in the early 2000s, where Teladoc and MD Live were first getting started as sort of these like startup direct to consumer telemedicine companies. And they would just be sort of a FaceTime with a patient. And that model works really, really well. But for sometimes you get these situations where you can't do very much, right? You can't touch the patient. You can't, do lab tests and things like that. Especially when you're just talking to a patient for the first time, right? And that was sort of like the genesis of all this. And the difference between that and what you guys have had to do is that you had an existing relationship with the patient. So you have a history with them. You're able to give more sort of longitudinal chronic care because you have this long-term relationship with those patients. And so my book starts with this concept that audiovisual telemedicine at this point should just be the norm, and policymakers and lots of healthcare organizations just had to get around to it during COVID-19. And policymakers still a lot of them don't quite get it. How can the doctor possibly talk to me over video? How can they care for me over the video, right? That's still a concept that's bewildering to a lot of people based on the fact that it's not widely accessible just yet. But virtual care is so much more than that, and it's going to continue to evolve to be more than that, in that we have the ability to collect real-time data from patients in the home. We have the ability to engage with patients differently. We have the ability to automate a lot of sort of manual tasks that physicians have to fill out and have to do all the time. And so the book takes telemedicine a little bit of a step further to talk a little bit more about what's the next generation of telemedicine and virtual care. And that's actually collecting real-time data on patient conditions from the home through a model called remote patient monitoring, remote physiological monitoring. And that really gives the telemedicine physician eyes and ears on the patient's condition in the home. Now, at ChenMed, you guys don't really necessarily have the same problems as a lot of the other primary care and the fee-for-service providers, because you already see your patients so often, right? You see your patients a couple times a month. They can come in, every other week if they need to. You do your love calls out to patients to try and talk to them. But a lot of providers just really, they don't do that. They see their patients every 3 months. They see their patients every 4 months. And so the idea behind the book and remote patient monitoring is, can we actually automate patient check-ins? Can we collect patient data when they're not in the clinic to be able to help in the fee-for-service system or in value-based care arrangements actually, impact clinical conditions and catch things before they go bad? And so the idea is, you have a hypertension patient, for example. You see that their systolic is, slowly climbing over the past couple of weeks. You're able to see that in real time and reach out to that patient, even though they might not have come into the clinic for another couple of months. So that's really the premise of the book.
It's even with establishing new patients, yes, there's the pathophysiology, there's the medical component with whatever medications they're on, whatever treatments that they have, or specialist doctors are seeing. But there's a trust, establishing that relationship. And with chronic disease management, especially when the doctors are focused on influencing positive behavior changes, you can do a lot in this virtual manner. Mm-hmm. But so far as collecting like data in a virtual manner, we can do so much. My father-in-law has one of those those monitors for the EKG strips.
Mm-hmm.
It's incredible, to be able to see. He says he's doing much. He's completely fine now, but there was a time when he wasn't feeling well, and he had an arrhythmia, and he was able to quickly check his rhythm strip, and we were able to see what was going on with him. That was incredible. This is just within the last couple of years,
Exactly.
and instantly know what's going on.
Yep. And those types of devices and wearables like Apple Watches and different devices are becoming more ubiquitous in our society, and especially even those that are medically grade and FDA approved. And so what you're able to do is start to create this sort of connectivity and this culture of health when the patient's not necessarily always in the clinic. You can sort of have sort of that ability to see what's going on, to automate alerts. If you see, okay, this patient's been deteriorating the past 3 days, like we should do something about this, or we need to reach out to this patient, or we even need to go to this patient's home because things seem like they're not doing super well. There's been a change from their baseline. And that type of data collection to be able to manage patients in real time is where things are going. And it's going to take quite a while to get there. And, there's no reason to believe that patients won't ever need to come into the clinic again, right? You sometimes need to be in person with somebody.
Sure.
You need to have difficult conversations with somebody in person. You need to be able to take blood. You need to be able to do certain procedures. So it's going to be a sort of hybrid model between the two, but it's nice and convenient for patients. If you're really just doing something where you're talking to the patient and you're trying to coach that patient on behavior change, or you're just trying to check in with that patient, it's sometimes a little bit better to just do it from the comfort of the living room. Or for patients that may not be as mobile or may have some difficulty being transported, for example, you're able to actually provide those services in the home. And so the book really goes into a deep dive on sort of the peer-reviewed literature from a clinical perspective of what do we know about remote patient monitoring right now? What do we know about it in terms of chronic care? What do we know about it in certain subconditions? What do we know about it in terms of cost? What do we know about it just in general? So there's a big sort of literature review component to it that's a little bit more scientific. And then there's interviews with people who, are performing telemedicine interviews, people who run remote patient monitoring programs, to really talk about that frontline clinician's perspective as well, to add color to the literature, because nobody wants to read a stuffy textbook. We want to know what people actually think about this and how it actually works.
Do you have anything in there about AI? I mean, I know it seems like I've heard the VAs working on a system that they can predict when people might start having suicidal ideation. And the real question is should they be doing it? And what would it be like to get a call from somebody saying, are you thinking about hurting yourself? But I know AI can detect patterns when the human brain can't. And I just
Mm-hmm.
wonder what you're seeing on that front as well.
Mm-hmm. Yeah. So there's a lot of work being done in predictive analytics on both like electronic medical record data, on real-time remote patient monitoring data. I'll tell you that I'm not an expert in artificial intelligence. I talk a little bit more about the ability to do analytics, but what I really looked at is more sort of like the human touch in being informed by the data. So that's really sort of human physicians, human nurses, human caregivers actually using this with automation in mind, right? So we're talking about analytics. We're talking about trending vitals over time. We're looking at trends with that. We're pulling out alerts automatically that goes to the team when a patient seems like they're out of their normal range, right? So it's that sort of intelligence that's built into sort of the monitoring platform that a lot of companies and a lot of healthcare organizations are sort of working with right now. But I don't go in too much depth with things I don't know that much about. And so the sort of higher level predictive analytics, machine learning is not pretty heavy in the book. But I do allude to it in some areas, and I usually just hand it off and say, there's a lot of work being done with this particular data set with artificial intelligence, right? To be able to predict when this patient might deteriorate in a month or 2 months, or who's got rising risk or falling risk at the end of the day. So that's really the extent of which I talk about it in the book. But there are some really good books out there that take it to the AI level. I'm just not qualified for it.
Okay. Yeah, I mean, I think the holy grail would be to find out, a week before somebody's going to get admitted to the hospital, and
Mm-hmm.
in time that you could do something about it. But yeah, it's do you talk anything about smart homes? I think I read one time about, I mean, we talk about all this high tech medical, equipment that we can computerize, but an engineer somewhere had computerized the toilet. And,
Hmm.
people who get diabetes, if their diabetes gets out of control, they start urinating more. So
Hmm.
they actually an alert would go off if the toilet started flushing more frequently. And that would give people an indication that maybe their diabetes was going out of hand.
Yeah, absolutely. So I don't specifically talk about the toilet example. I have heard about that as well. I've also heard of some of the toilets that'll actually analyze the stool chemistry, and be able to make some sort of predictions and or like analysis based on what they pull out of there. But I really focus on wearables, just because they're passively collect data. I really focus on, your just typical sort of blood pressure cuffs, your typical EKG monitors, for example, like you were referencing there, Dr. Sayed, and sort of the more mainstream ones that we know stuff about that are actually used in programs right now. But the smart home concept is really interesting. And there's actually a lot of companies out there that do work on smart home technology for health purposes. And I do talk about one company in here that does do machine learning. I don't dig into the machine learning, but they have a wearable that can predict depression. They have a wearable that can predict falls. They have a wearable that can predict, just general deterioration in patients for certain conditions that they wear on a wrist. And they're actually installed in senior living facilities and nursing homes to be able to prevent those falls. And they also sell it commercially for older adults that reside in the home. And basically, it's got sort of like gyroscopic type things inside the the watch that the engineers build. And when you take a baseline for patients when they're eating and they're going through their activities of daily living, and then if they sort of diverge from that baseline, it sends an alert to family members and to care teams saying, hey, look, this patient seems like something going on cognitively or with their gait or with their balance that may result in a fall in the next week and a half. And that type of technology exists right now. It's being used right now. And so that's the type of thing I talk about in the book as well. But we all know here on this podcast, or it's not really a podcast. It's like a blog or like a webcast. What do we call it?
Well, it actually the audio gets extracted from this and it gets put on all the major podcast platforms now. Yeah, that happened.
Oh, that's new. That's new.
Yeah, that was just this year.
Oh, well, cool. So this podcast, and what's really, really interesting is that there's a convergence between value-based payment models and these types of technologies, right? When you shift to full risk or you shift to a value-based payment model, you must do something different clinically to actually generate shared savings or to be able to meet the goals of that value-based payment model. As you guys know better than anybody, you have to clinically change the way you care for the patient, and that can be in low tech innovations. It can be low tech clinical models, right? You can also use some of this high tech clinical models that really allow you to proactively care for patients and try and prevent those ED visits, prevent those hospitalizations, because you have eyes and ears on a patient in the home. And because of the ability to sort of say, hey, look, I would not have known this before. I have this trending data from the past 2 months. I can see that the dosage I put out there for you is probably not quite enough because I see you're trending a little higher than I expected. So why don't we increase your dosage proactively rather than waiting for something to go wrong or for you to show up at the next visit?
Absolutely. Absolutely. If we've learned anything with making the switch from this heavy in-person model to a hybrid model, to extreme virtual, and now to this hybrid model we've got right now, is that we know you can provide so much medical care outside of the primary care delivery system. I mean, we can provide a big chunk of medical care in the home setting, and that's really where most of it ought to be. When the average American is only 37, 38 years old, it blows my mind away that half of medical care, at least pre-COVID, was delivered in the emergency room setting with this type of, and we're not talking about thousands of dollars either for the strip monitor, the EKG monitor. I think it was like $100, $200. We're not talking
99
about
bucks.
Yeah, something like that. It wasn't a major expense. So that hurdle is no longer there. And the networks are there. The networks are now there. The ability to connect has never been better. It's only going to get better.
Yep. Yep. So if you look at the country in 2018, people over the age of 65, 75% of them owned a smartphone in 2018. This is from Pew Research Center. Now in 2021, it's closer to 85, 86%. And so the ability for people to access these types of care programs where they actually have an experience on the app with a lot of sort of automated information, they can see their own data, they can access their care team via messaging, they can call their care team from this application. It just provides a better access experience, and it improves communication between doctor and patient. And I know at ChenMed, Dr. Sayed, you talk about you give your patients your cell phone number, right? They can call you and talk to you. And that's the same type of sort of way to do this, right? And ChenMed, again, you're a special organization, but for a lot of primary care organizations, a lot of health systems, they don't really quite have that mindset. They're still in this sort of churn and burn fee for service, mindset where they really don't talk to patients. They don't take the time to spend with patients, and they're closed at 5 o'clock. And so the ability to kind of take these technologies to kind of build a high touch model of care that we know works from you guys, and sort of use technology to sort of extend these offices and use nurses to extend sort of the touch points with patients is really helpful for a lot of the fee-for-service clinics, which is unfortunately still the majority of how we pay for primary care in the country. And so that's really where the book really focuses, and particularly in Medicare. So Medicare in 2018, 2019, they rolled out these remote physiological monitoring codes, CPT codes, to be able to bill. And so it's really enabled companies like the company that I co-founded and companies that we write about in the book to actually, help practices like adopt these technologies and make them meaningful to actually reach out to patients. And that's really at the end of the day where a lot of the book focuses, because it's become accessible to your average primary care physician. They're able to actually, get this paid for in a sustainable way to offer these types of programs to their patients because there's funding for it. And we all know that the activities often follow the funding in fee-for-service, which is something that's really good. But again, like I said, where I still see this actually really going as value-based care starts to accelerate, you're going to start to see value-based care organizations and primary care organizations saying, hey, can I do some things with technology? What do I need to do in the clinic? What do I need to do? Using these new models to be able to provide just better chronic care for my patients to prevent those high cost episodes.
And people are more open now about learning about their body, their vital signs. I was just in Puerto Rico a couple weeks ago, and every restaurant was at 50% capacity that we went to, and they had the temperature checks. This is remote. You just stand and it checks your temperature. People were more open to it, and I feel like, and even with where I work out in the, I have a heart rate monitor, and that's being broadcast on a screen, and I'm able to see when my heart rate is in the 140s, it's in the 150s, 160s. We're able to see and respond to that real time. I mean, this is taking like a lot of the information that we have today that we use to help inspire or motivate people to make better lifestyle choices. This is just a whole different level. It's not just absolutely a single blood pressure check twice a year.
Yeah, it's taking it in real time. And Faisel, that's a perfect point, because it's the other thing I wanted to bring up today, which I cover heavily in the book. A lot of people think remote patient monitoring, remote physiological monitoring is just to kind of catch those acute episodes, right? It's not. It's giving patients the power to see and use and measure their own health. And when you give patients sort of that autonomy, and you give them that sort of self-efficacy back, of saying, I can measure my own health, I can take this into my own hands, it provides them sort of more confidence in helping to self-manage and make those behavior changes, because they can connect their activities to what their blood pressure or their blood glucose looks like on a daily basis. It becomes an educational tool and an empowerment tool, as much as it is about just catching that high blood glucose that's dangerous, or that high blood pressure overnight, right? It's about patients saying, hey, doc, you told me about that sodium the other day. And I went home. I had the biggest pizza last night, and I took my blood pressure, and I saw that my blood pressure systolic went to like 160, right? And that patient made that cognitive experience and said, I saw this happen. And now that understanding becomes so much more solidified than just hearing it or getting it, right? And that's the power of these types of care models, is putting the data, the patient's own data, in their own hands, rather than
Sure.
having it just sit at the doctor's office. It makes it more real to them to be able to manage their own care.
Absolutely. We already know. We know that, even right now across the country, so far as medications are concerned, as a country, we only have 50% compliance with
Mm-hmm.
medication regimens. So it's not just prescribing the medication, prescribing the treatment is not enough. It's definitely,
Mm-hmm.
and I see that with all the work that's being done with the closed loop, the continuous glucose monitors and the insulin
Mm-hmm.
pumps responding. I mean, this is fascinating. We're moving
Mm-hmm.
into a world where thinking about just a patient checking the blood sugar just once a day, or even some of them checking it 3 or 4 times a day, as opposed to having a continuous monitor, it's just going to seem like it's
Absolutely.
something from a different time.
Absolutely. And that's part of what we talk about in the book too. So Dexcom Cgm was a big one that came on the market. And, the idea that patients loved it. They can see their blood glucose. They know when they're getting high. They know when they're getting low. They know how to manage it in real time. And just think about the relief that is, that having all these sort of spot moments. And diabetes care has been way ahead of a lot of other conditions for a long time, because it's been core, it's been necessary. Patients have been sort of trained to take their blood glucose before or after meals, right? That's been sort of a core for a long time. But there's other conditions we can monitor now, right? We got pulse oximetry for COPD patients and congestive
Yeah.
heart failure patients. We've got scales for patients who are in weight loss care. We've got smart scales for patients in congestive heart failure. You want to see if somebody added a little bit extra fluid weight on their lungs and their heart overnight, right? You're able to sort of see that, and that trigger can go back to the clinic and congestive heart failure clinic, and that nurse can say, look, we got to get you back in here, or we got to get you to take another Lasix, right? And that type of insight into what's going on with patients today, right now, is really, really helpful. Otherwise, patients may get scared. They may not know how to access their doctor, and that's when they end up in the emergency room, right? And that's when you can reach out and have an effective sort of like intervention before you end up with somebody having difficulty breathing and having to go
Yeah.
to the hospital.
Well, hey, let me take a quick break. I want to take a quick 20-second commercial break, and then we will come back and talk a little bit more with Robert about some closing thoughts about how we can use technology as an extension of the doctor-patient relationship rather than letting it be a barrier.
Yep.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And
Are
we're
you guys
back.
going to Delaware?
It's Robert, it's definitely not a question of if.
Did I see a dot on? Was that Philadelphia or was that Delaware? I saw a dot on the map up there.
That's Philadelphia.
Okay. All right. It was close to Delaware. My grandparents are in Delaware. As soon as you guys get up there, you let me know, because I'm sending them over to you guys. But Faisel, your point about how it's an extension of the doctor-patient relationship for sure. And there's a
Absolutely.
lot of companies out there and a lot of organizations that are trying to like do away with the human beings part of healthcare. And that's certainly not what this book is about whatsoever. There's a lot of people who are like, oh, we have AI, we're automating, patient care for chronic care, dosing of how patients should change their meds. And I'm like, okay, the intelligence is good. Automation is good when you have repetitive tasks and things like that people don't need to be doing. But that relationship is key to getting patients to sort of stay adherent and to be able to ask the tough questions. And that emotional piece of patient engagement is really, really important. And part of the book talks about this emerging science in psychology of how patients relate to their health, how they relate to healthcare services. And there's three elements. There's the behavioral element, how patients behave in light of their condition. That's care plan adherence, that's medication adherence, that's, am I going to listen to my doctor about my, lifestyle changes? There's the cognitive, which is what do I understand about my care? How can I measure my care? And then there's the emotional piece. And I'm sorry, we know that computers can do a lot of stuff with empathy, and we know computers can do a lot of stuff, both good and bad, from sort of what we've seen with Facebook in recent weeks. But it just will never replace having a trusted human being to talk to. And that relationship is crucial. And it's really all about empowering the caregivers, the care team, and the physicians to be able to better manage their patient care by giving them more insights, automating stuff that doctors get burnt out on, and really focusing in on, what the patient really needs from that caregiver at the end of the day.
Yeah, we must embrace it, and we should be the ones leading the care delivery, whether it's digital with this virtual care, or it's with the care teams who are in direct contact with the patients. It's got to be physician led.
Absolutely. And at the end of the day, it comes down to trust. And I don't really trust the tech companies all that much, but we know patients trust nurses. We know they trust doctors. And so that's really where you're going to have success if you're able to marry the technology with what we know leads to sort of good patient outcomes and good experiences for patients in healthcare. We don't want it to be a bad experience. We want patients to have a good culture of health, and we want it to be sort of a, as you guys put it, sort of a loving relationship.
Yes, they've embraced weekly phone calls from our staff. We call them, like you said, we call them love calls. Even daily text messages, simple little reminders. Hey, don't forget to get your flu shot. Hey, it's hot outside. Make sure you drink some extra water today. These small little touches. It's the little things that help build the big trust, so that the patients come to you first rather than going to the emergency room.
Yep, absolutely. And quite honestly, nobody really wants to go to the emergency room, and nobody wants to be in the hospital. So if you're able to do the outreach and build the experience for patients in primary care and make sure that you're meeting patient needs, it's easy to prevent those things, unless you have a serious medical condition, right? Then patients need to go to the hospital. But
absolutely, absolutely, we don't want them going anywhere else.
Yeah. So that's sort of the story of the book, and so I wrote it during the pandemic, and it was not a great idea because I finished my first book just as the pandemic began, and I had a publisher call me, and they said, "Hey, we'd like to publish another book on virtual care and telemedicine. We think it's going to be a big thing." And I said yes because it was a bigger publisher, and it was not a good idea. I thought I was going to have so much time because we were going to be quarantining for so long, and I was working. And at the end of the day, I was not interested in sitting at my computer writing anymore. I wanted to go for a walk in the forest. And so it was quite a challenge to get it done. And I did turn it in 2 months after my self-imposed deadline, which, my editor was gracious enough to accept. Although towards the end, she was like, "You just got to send me the book." And the emails were like, "Okay, take your time, make sure it's good," for the first month afterwards. And then towards the end, I was like, "You guys send me the book." It's like, "Okay, here you go. You can have it." I looked at it. But Dr. Sayed, you're acknowledged in here for your interview, and really appreciate your insights, and obviously learned so much during our time talking on the show during the early days of Faisel and Friends, and really shaped the way I thought about sort of how the human beings need to be involved in care. And I did highlight some of the work ChenMed did when I was drawing parallels between high touch care in the clinic setting and high touch care virtually, right? And that's sort of what you need to be able to really drive good outcomes for patients with chronic conditions. And in fee for service, it's not necessarily possible, but it was great to be able to learn from both of you, Dr. Dan, you as well, to learn from your experience and be able to incorporate that into how I think about virtual care.
Ah, wonderful. Thank you, Robert. I mean, you're always going to be, this is always your show. When you have time to come on, you come on. I mean,
Yeah, I got super busy, and we launched a it's about 5 or 6 thousand patient program for hypertension and remote patient monitoring at an FQHC
Wonderful.
in Alabama.
Awesome.
And so we were rather busy over the summer, making sure that everything was rolling out effectively. But there's about 23 medical centers in Alabama rolling out our program right now, and
Wonderful.
patients really like it. They like having the devices. They like that connection to our health coaches and their care team, and so that's been a great learning experience where the vision's been able to come to life in sort of a pretty nice way. And yeah, so was a little busy and got a little overwhelmed with doing too much stuff after work. It takes
No,
some self time.
no, I completely understand. I'm excited to hear what's going to happen in Alabama with that hypertension project of yours. Almost half the country suffers with cardiovascular disease, and 80% of that is fueled by uncontrolled hypertension. By
Hmm.
hypertension, and
Yep.
and 95% of hypertension has zero symptoms.
Hmm.
So by the time they're having any symptoms, it's a bad situation. So if you can help them with monitoring it at home and help them see, we could all use some motivating to live healthier. We have choices. We
Oh,
all have options.
for sure, for sure. I mean, I thought about enrolling myself in the program sometimes with trying to increase my activity levels and things like that, sitting at this desk so much. So we can all benefit from a little bit of extra gym action. My gym has actually been closed for the past like month and a half because of a fire. So
Oh,
I've been like kind of gymless for a while, and I decided I was going to go back. So yeah, I that's my other exciting development. I see. Um, and yeah, so I missed the show. I missed talking with you guys, and continuing to profess the value of excellent primary care and value-based payment, obviously. So, but I know you're carrying on the show well beyond me. It was always going to happen that way, because you guys are, this is what you do.
we're definitely connectors. I feel it. I feel it. I feel it more now than I ever did before. That's for sure.
Yeah,
Well, Robert, thank you
absolutely.
so much for joining us.
Yeah,
And
I'm
Dr.
so glad to be back.
Yeah, and Dr. Dan, another great night.
Yeah, great conversation. It's always interesting to see where technology's taking us.
Yeah. And to our audience, thank you so much for joining us this evening. For more information about tonight's topic and to explore career opportunities with ChenMed, remember, we're on track to open another 500 centers over the next 4 to 5 years. You're talking bringing on another 3,000 plus doctors, plus all the teams of people who need to support them and the patients. Please visit chenmed.com. We believe access to primary care is a right, not a privilege.